So, okay, now we're live. So, good evening, everybody. Good morning in Latin America, in America. I am very happy and excited to have Professor Gret Hens with us here in this new chapter of Barcelona Rhinology School. Now we are trending more to the pediatrics and the future. So I'm very honored to have Professor Hens talking about his enormous experience regarding cleft patients. For sure, this will be an exciting lecture, and hopefully we can learn a lot. Thank you, Gret, for accepting this invitation and for being with us here. So whenever you want,
Yeah,
you can. I will share your screen now.
yeah.
You can go to your presentation.
Okay. Okay, that's okay like this. You can
Mm,
see it.
you're in presentation mode.
Yeah.
I think you will have to do it again. So like
Stop sharing and share
sharing
again.
exactly.
Okay. So
And
meanwhile, I will introduce myself a little bit.
great.
So I'm Greet Hens. I'm a pediatric ENT surgeon in Leuven in Belgium. I'll try to share again. This should be working now.
Yeah, now perfect. Yeah, perfect. Amazing.
Okay, good. So I'm a pediatric ENT surgeon, and I'm mainly interested in um, cleft lip and palate surgery. I'm the coordinator of the Cleft team of Leuven, but also auricle surgery, pediatric head and neck, and airway surgery. But the cleft lip operation is definitely one of my favorite operations. So I'm very happy to be invited here to uh, discuss some things with you. And since this is the rhinology school, I'm going to focus on the nasal deformity. So we'll start with a little introduction, going over the incidence of the disorder, embryology, and anatomy. But not before I show you some pictures to highlight the heterogeneity of the disorder. So no two patients with a cleft lip are alike. Here you can see patients who all have cleft of the primary palate, that is of the lip, uh, with or without the alveolus. And as you can see, there is a huge variability. On the right side, you can see a complete um, left-sided cleft lip and alveolus, but you also have incomplete clefts where only the lower part of the lip is clefted, or even this one is a microform cleft where there is actually no cleft at all, but you can see the misalignment of the segments and of the orbicularis oris muscle. Um, it's usually on the left side, the cleft lip, twice as often on the left side than on the right side. It's not really understood why. And it also occurs twice as often in boys than in girls. So this is a cleft of the primary palate only, but even more frequent is a cleft of the lip and palate, a combination where you can see here a view on the hard palate, and you can see the cleft going through the left side. So there's a connection between the mouth and the nasal passage on the left side. And the red mucosa you can see is a mucosa overlying the vomer, which is only connected to the right palatal shelf and not to the left. So this is a unilateral left-sided cleft, but cleft of the lip can also be bilateral, as in this case, where you can see that the vomer, the nasal septum, is not connected neither to the left or to the right side. And the mid part of the alveolus, the premaxilla, you can see here, that's the part that usually contains the four upper incisors. and is often very protruded because there is no counter pressure of the orbicularis oris muscle. So this is the most severe type of clefting. It's not that rare, a cleft lip or a cleft palate, when you take all the subtypes together, so the cleft of the lip and palate, and the cleft of the palate alone. And it has an incidence of about 1 in 700 births. That means that it's the most frequent craniofacial congenital disorder, and that it's the second most frequent congenital disorder overall. The first one are the congenital cardiopathies, the heart problems. And as you can see, about 70% of these children have a cleft lip, and the majority of these have a cleft lip and palate together. Just briefly, something about embryology. When I see parents for prenatal counseling who expect a baby with a cleft, they always want to know how this happened, what is the reason. And it happened actually quite early already. So you can see this is 5 weeks of gestation. Already then, the entire embryo is only about the size of a pea, and already the face is forming. And you can see here the primitive mouth, the stomadeum, with the frontal nasal process above it. And this frontal nasal process will then give rise to a medial and a lateral nasal process surrounding the nasal pit. And here you can see the maxillary process, which grows around week 6 medially and will fuse with the medial nasal process, and it's that fusion that does not occur in a cleft lip. Why it doesn't occur? Well, in patients with a cleft lip, in about 90-95% of cases, we cannot really answer that because it's multifactorial, and many susceptibility genes and environmental factors may play a role. So it's bad luck, so to say. In a small minority, it's really monogenic. So then it's a syndromic form of clefting, and these children may have other associated pathologies. So the cleft is actually a non-fusion in early embryogenesis, but this will give rise to a number of secondary deformities. As you can see here, in the cleft lip, the orbicularis oris muscle is also clefted, and it's attached differently. So one part of the muscle is attached to the columella, to the anterior nasal spine and anterior septum, while the other one is connected to the alar base. And of course, already in the womb, the baby uses the muscles, and these aberrant muscle forces will cause a distortion of the alveolar segments, but also of the nose. And that's what we're talking about today. Well, there's actually a spectrum of severity of cleft lip, but therefore also of the nasal deformities. It's mild in an incomplete cleft lip, but can be pronounced in a complete wide cleft lip and palate. So what are these deformities? They're always, well, they differ in the severity, etc., but the direction of the forces is always the same. So there is a pattern in these deformities. And as you can see, the alar base on the cleft side is displaced. It's displaced laterally, but also inferiorly and posteriorly, while the columella and the anterior septum are pulled towards the non-cleft side. The posterior septum will be bended towards the cleft side. That's for a unilateral cleft lip. In a bilateral cleft lip and palate, I already told you that this maxilla will have an unhampered forward growth because of the lack of the counterforce of the muscle. And this will result in a lateral and a posterior displacement of the alar basis, often a very short columella and a broad under-projected tip. So to repair the cleft lip nasal deformity, there are several time points and stages in the repair. And in wide clefts, this may already start soon after birth, because then you can consider to do pre-surgical orthopedics. What this is actually an early orthopedic treatment. Well, it had been shown that the cartilage of infants is it has a very high plasticity, and you can actually mold it in a different shape quite easily. And this knowledge comes mainly from the auricle deformities, where you can do ear molding, but you can also do this in a cleft lip patient, and you can mold the alveolar segments and the nasal cartilage to decrease the distance between the alveolar segments, so to decrease the width of the cleft, making the surgical repair easier, and also to reshape the deformed nasal cartilage. There are different options to do this, different techniques. The most easy is just the lip taping. That's just a wound adhesive strip across the cleft, which pulls the segments together, and parents have to change these tapes daily. And because of the force of the tape, as you can see, the both segments will move together, and you can also see some positive effect on nasal shape. And in wide clefts, it is done to before, well, we start as soon as possible after birth, until the time of the lip surgery at the age of 3 months. It needs to be it works best if you start soon after birth, because the high plasticity of the cartilage has a relation with estrogen levels in the blood of the baby coming from the mother. So that's only early in life that works so well. More sophisticated is the nasoalveolar molding. Therefore, we need the help of the orthodontist in the cleft team, and she or he can make a palatal plate, which is then fitted to the baby. We have to take impressions first, and by adapting the shape of this plate every week, you can again bring both maxillary segments together and decrease the width of the cleft. But you can also add a little attachment which does some nasal molding as well. It pushes up the alveolar, the lower alar cartilage to shape it and make it more rounded. Okay, so that's very early treatment. The first surgery will happen when the baby is 3 months old. This time point is quite widely accepted because it's an age at which anesthesia can be done safely. Though there are cleft teams around that do perform the lip surgery neonatally at day 3 after birth. But this has I think this has certain risks, of course. And it doesn't make the repair nicer because it's even smaller, so you have a larger you have less margin for mistakes. So we, like most cleft teams, wait until the age of 3 months to repair the cleft lip. I'm going to focus today on the nasal deformity, but there's actually many things going on during a lip repair. You have to make sure that you really repair the orbicularis oris muscle well to make it the repair pleasing also in movements. And also you have to achieve lip symmetry. One problem you will always face is that the lip at the medial side of the cleft is always too short. It's always shorter than the normal side. So you have to use techniques, ways of cutting the skin to increase the length of the lip, which has been done here. But the most difficult part, and I think every cleft surgeon will agree with me, is to achieve symmetry in the nose at this early stage. And there is some debate about whether you actually should operate the nose at the age of 3 months, whether you should do a primary rhinoplasty, because there are some surgeons who say you should avoid it to reduce scar tissue formation and to avoid growth inhibition, so that a later secondary rhinoplasty at adolescent age is facilitated. I think it's mostly probably adult surgeons doing only secondary rhinoplasties who are convinced of this principle, because more and more it's accepted that an early correction results in a less severe secondary deformity, and this is actually quite important for the psychological well-being and self-esteem of the patients with a cleft during childhood and definitely during puberty. And McComb has studied his cases longitudinally and shown that if a primary rhinoplasty is performed, the symmetry achieved is maintained into adulthood. And it's not to say that it's perfect symmetry, but it's much more symmetrical, of course, than if you wouldn't do an early correction. The extent of primary rhinoplasty differs between surgeons. You cannot solve every problem. I think there's no surgeon doing osteotomies on a little baby, for instance. What I do is a conservative rhinoplasty, but I make sure to reposition the alar base in a symmetrical position, and I also try to improve the symmetry of the lower alar cartilages. Some surgeons would also do a septoplasty at an early age, but I don't, out of fear of hampering nasal outgrowths.
Great. Can I ask you a question? Do you
Yeah,
use
sure.
any some graft to reshape the ala, or just
No, no
no
grafts.
no graft?
I'm going to show you what I do, but also, everything is there actually. It's
Okay.
like deformed because of the muscle forces, but you can bend it in the right
Okay.
position. And also for the lip repair, you don't need any additional tissue.
Okay.
And also not cartilage grafts at this age.
Yeah, because
No.
the ala is like concave, no? The
Yeah. So I'll
so
show you how I try to
great.
solve that.
Okay.
Yeah. Well, this is an ugly picture. I'm sorry.
No,
But it
no.
shows, well, first you have to really release the alar base aggressively, because well, it's, as you know, it's pulled laterally, it's pulled inferiorly, it's pulled posteriorly, and to put it in the correct position, you really have to free it from its skeletal attachments. And it's not difficult in small clefts, but in wide clefts, you really have to do quite a bit of dissection to free it, so you can really mobilize it and put it symmetrical to the other sides. So that means freeing it from the anterior maxilla, freeing it from the piriform aperture, and to bring it forward, you sometimes even have to incise the lateral nasal wall to free to make this forward movement possible.
Okay.
So that's one. And then if you really freed the alar enough to put it where you want it to be, then you try to, as you say, make the reduce the buckling of the cartilage, make it round,
Yep.
and you can do that by dissecting, and that's a Macomb technique. Via the lip incisions, you can make a tunnel and dissect between the skin and the lower alar cartilage from laterally and from medially. So you go in between the crurae, so that your cartilage can move independently from the skin. And then you can actually put it in the correct position because if it moves independently from the skin, you can actually really make it round again. And
Okay.
then you have to fixate it in that position. So it's very different from a secondary rhinoplasty with the cartilage grafts
Yeah,
and
yeah,
really,
yeah, nice.
bending and to keep it in that position, you can, well, there are commercial stents available, for instance, or self-made stents like I used here. But often I just use PDS stitches, which are under the skin, but the knot is in the vestibule
Okay.
to fix the skin in the new position, in the new relationship with the cartilage.
Okay.
Okay,
Yeah, yeah, nice.
so that's. But so I don't do anything on the bone, or I don't do anything on the septum. But of course, because you do the lip repair and you release the muscle and you release the anterior nasal spine, and you already bring you create symmetry, and you bring the anterior nasal septum towards the cleft side. So but that's part of the lip repair. It's not
Yeah.
really a septoplasty. Okay, in bilaterals, well, there are many surgical protocols for lip repair in unilaterals. In bilaterals, there are even more. um, the way we do it in Leuven is we do it side by side, so it's a bit different, I think, than most surgeons. But this gives us the opportunity to really do a thorough dissection on both sides. And well, we actually also repair the hard palate during lip repair, and so we can do both sides as well. Which, if you would do them at the same time, um, you would have a risk of devascularizing the premaxilla, which is a disaster. So
Yep.
we do this is here the well, this was a prematurely born baby, and then I first repaired the broadest side, the widest side, the left side. You actually make it into a unilateral cleft lip and palate, and then the other side as well. And so for the nasal repair, it's the principles are identical as in the unilateral cleft lip repair, but it's done side by side.
You're amazing.
Okay. It's so even in, I think it's not always perfect. I think the nasal repair does remain the most difficult part of lip repair. Um, but even in these, yeah, you can see this is an extremely wide cleft. The alar cartilage is extremely deformed.
Yep.
He also has a neonatal tooth, which cleft babies sometimes have. We remove them. Um, but here you can see the boy at the age of 10. So it's not perfect. The symmetry is not perfect, but it's acceptable. And yeah, I think it's much better than if you wouldn't do the primary rhinoplasty with the
Yeah.
Macomb dissection, etc. But of course, if it's not perfect, patients may opt for a secondary rhinoplasty, and that's the next part of my talk. And I have to give courtesy to my colleague because in our Cleft team, it's not me who does the adult rhinoplasty, but it's Professor Hellings, my colleague, who has a very big experience in rhinoplasty surgery, and so he's also treating our adult cleft patients. So we send our patients to Peter at the end of their cleft treatment if there is an indication and if they are asking for it or wanting it. So that's ideally done after the major outgrowth of the face to have a stable result. And also, as you may know, cleft patients often have a growth retrusion of their maxilla. They can have a class 3 malocclusion. And they often need orthodontics, and sometimes they may need osteotomy to treat the malocclusion, which will also change, of course, if you bring the maxilla forward, it will change the shape of the nose as well. So ideally, the secondary rhinoplasty is done after the malocclusion is repaired. But this is not a dogma. I think you have to take into account every individual patient's wishes and psychology. And if patients are really bothered by the nasal asymmetry during puberty, or we do sometimes offer them an early rhinoplasty, and we discuss it with them that it can be done, but it may mean that there has to be a revision later. So even if it means it's two surgeries, it's sometimes worthwhile helping these patients who are really, really bothered by the nasal asymmetry.
Great.
Yeah. Something about the secondary rhinoplasty. Or do you have a question?
Yeah, yeah. I will. Yes. So,
Shoot.
what do you do with those patients that they have like nasal insufficiency or like deviated septum and
Mm-hmm.
uh, nasal breathing problems? Do
Yeah.
you schedule them for septoplasty or you wait for the rhinosepto,
Well,
secondary rhinosepto, or
yeah. Normally we would wait.
you will wait? Okay.
Yeah. In majority of cases, we would advise them to wait until the secondary rhinoplasty to do it all in one surgery. But again, I think there are no dogmas. I think
Yeah.
if a child or a young adolescent is really bothered, well, you can discuss the advantages and disadvantages of doing it early with the patient and their parents and decide.
Okay.
But usually we would wait until the rhinoplasty.
Perfect. Great.
Yeah. These are difficult secondary rhinoplasties because there's well, there may be a big asymmetry, but also a lot of scar tissue from previous surgeries. And again, the same deformities are present. It's like a relapse or are not sufficiently dealt with deformity that was there in the beginning. So there are problems in the nasal bony pyramid, in the nasal tip, and the nasal septum. So if you see the bony pyramid, you can see it's usually deviated to the non-cleft side with a flattened nasal bone on the cleft side. The tip, and these are really things I think that you that could have been handled during primary rhinoplasty. So that the lower position of the lateral crus, the buckling of the lateral crus, a bifid nasal tip, and a lateral position of the alar base are typical deformities in these patients with a cleft lip. The septum, yeah, you can think about how the muscle pulls. So the anterior septum will be deviated to the non-cleft side. The posterior septum will be deviated to the cleft side. And so these patients often have nasal obstruction on the cleft side because of the septal deviation, but also often, not so much in this case, but often because of a stenotic vestibulum, because of the scar tissue. And here you can see the typical deformity in a bilateral cleft with a short columella and a broad underprojected tip.
Sorry, great. Do
Yeah.
you do you see, like, when you do like this primary rhinoplasty
Yeah.
in young kids, that the symmetry of the nostrils, it's maintained,
Well, it's not always
improved,
perfectly maintained.
but
What you what you can see is where you the more symmetrical it is, I think, the more symmetrical it will stay. But you
okay,
do sometimes have relapse during growth, or just uh, if you look like this in worm's eye view, then you often see a bit a more horizontal position of the nostril on the cleft side.
okay.
It's not. It's obviously not always perfect.
No, no, for sure, but it's better than not to do it.
Yeah, sure. It's better
Yeah,
than not to do it.
that's the
Yeah,
thing. Yeah, okay,
yeah,
great.
yeah. Um, if most of these secondary rhinoplasties are via an external approach, about 85% in our center. And I'm not going to go over all these rhinoplasty techniques because it's are the classical rhinoplasty uh, techniques, but you often need if you use the cartilage grafts, you often need extensive grafting in these cleft patients to um, yeah, address the deformities
Yep.
from septum, ear, rib. This is quite similar to other rhinoplasties. Something you have to take into account is the alar correction in the cleft patients. If there is a lateral alar position, that you may have to do an alar base, wedge, or sill resection, and uh, if there is a stenotic vestibulum, you can use a Z-plasty or a composite graft to try to enlarge it. In the bilateral cleft lip, of course, there's a need to lengthen the columella and increase the tip projection, for which you also use classical techniques like the columellar strut, etc. But you may also have to enlarge the skin of the columella, and you can either do that via a VY plasty, but Peter and I also often operate together on these patients. He does the secondary rhinoplasties, but I often join him to do a secondary lip repair. And then we can take advantage of this if there is a bilateral cleft lip, for instance, with a broad prolabium, you can actually use the skin of the prolabium to insert it into the columella, and then you have a double effect. You decrease the width of the prolabium, but you also can achieve a good lengthening of the columella and improve the nasolabial angle. So this is one patient where Peter and I worked together. He did all the cartilage work and I did the lip repair. But since we, but I could give him some lengthening of the columella coming from the lip.
Great.
And we often do this joint. So I think even if you're a rhinoplasty surgeon, doing adults and doing lots of rhinoplasties. For these cleft lip patients, it's in my view mandatory to be cooperating with the cleft team, um, to have a more comprehensive look at the cleft. There may be some uh, alveolar deficit below the nasal alar, for instance. So you may need your maxillofacial surgeon. You may need a lip repair at the same time. And this is one, again, a patient that we operated on together, where Peter did a nose and I did a lip. And then you can see that you really get a much more harmonic results, and you can get some rid of some of the stigmata of the cleft.
Yep. Nice. Nice result.
Yeah, we had a look at our the impact on self-esteem and quality of life of the secondary cleft after secondary cleft rhinoplasty, and yeah, found that on average, well, not even on average, that these were patients who were very satisfied with the result, even more than we found in the general rhinoplasty population. So although these are difficult rhinoplasties, these are very grateful patients. They're quite happy. But if you look at it in a bit more detail, you can see that they're mainly happy about the aesthetic results, um, and that increase in VAS score is less pronounced when it considering nasal breathing. So that's also something we tell these patients. It's sometimes difficult to improve nasal breathing in these patients, definitely when there is a stenotic vestibulum, and also most of the time you're actually narrowing the nose. It's usually the tip is broad and the alar is laterally displaced. So if you correct all this, the nose may become more narrow and breathing may become more difficult. So it's something really to counsel your patients that it may not be an improvement in breathing.
Yep.
Okay, so I think, well, I'm one of the surgeons in our team, but you need more than surgeons to have a good cleft care for your patients. You need orthodontist, geneticist, maxillofacial surgeon, pediatrician, dentist, speech and language therapist, and so on. So I'm really happy to be part of this team.
Amazing.
And well, just something to the pictures to end. It's always nice to look at pre and post-operative pictures, but even more so when they're printed on a cake and you can eat them afterwards. It's ideal. Okay.
Okay, great. Amazing, amazing talk, amazing results. Look, this picture is amazing. Thank you very much for this interesting and really easy to follow presentation. I think it was everything pretty clear. I I have with there is no questions.
Okay.
I think you covered everything, and it
Yeah, if
was
there are any questions later, people are
yeah,
very welcome to send an email. Uh,
yeah,
I'm
perfect.
happy to
Send
reply.
it to me. I will send it to you, and you
Okay.
can answer them.
Yeah.
Thank you very much. I think I hope to see you. I don't know if you're going to the rhinoplasty course in April, but uh,
Well, we may meet when you're
maybe
in
there.
Belgium.
If not, we will meet for sure in September. That we are organizing a course there with Laura.
Okay.
So thank you very much for your time and for this amazing talk. Hope we can start working together because now I'm in the pediatric rhinology team. So
Okay.
I'm very eager to start working and doing nice things, and
Yeah,
as you do. Okay.
yeah, that would be nice.
Thank you.
Have
Thank you
a
very
very
much.
nice evening.
You too. So thank you everybody for being with us today. Just a quick, uh, um, how do you say, announce. We are organizing our first dissection course in Granada. This will be Spanish and English uh, talks. The interesting about this course is will be like one head or one specimen for each participant, so you will have a lot to dissect and to learn, and hope you can join us. Okay, great. Thank you very much. Have a nice evening, and well, thank you for everything.
Bye bye.
Bye bye. I will